So, case number 1, let's get 2 minutes on the clock, and of course, our time starts now. I really love it when the automation starts playing up again. Right. That's all right. We will crack on to the answers here. I thought I had these bugs squashed after last week's live stream. Bear with me. That's okay. We'll get through. So, hopefully you've got some answers there. Cases like this, I've actually seen essentially exactly this case several times. And what we have here is a question about, well, why is this person iron deficient? And anytime we have iron deficiency, always think, is there enough iron going in? Is the iron going in able to be absorbed? And is there something that's burning through the iron stores faster than it should be? And so really there it's poor dietary iron intake. Now, far be it from me to presume that a 19-year-old university student may not have the greatest diet. That's fine. Of course, we are looking here at what is likely going to be a inflammatory bowel condition, and so there could be poor absorption through the bowel. And of course, if there is inflammatory bowel disease and blood loss through intestinal bleeding, we could be looking at that as a blood loss source, which will again burn through whatever iron stores are there. I've always found in real life, it's usually a combination of all these things together that contribute to iron deficiency, so always be hesitant to ever put down one single reason as to why someone's iron deficient unless it's very, very, very obvious. All right. Of course, we have another question lined up. Let's put 2 minutes on the clock, hopefully, and your time starts now. All right, so hopefully you are happy with your answers. Now, iron infusion is one of those things that we will often refer for. Where I'm working, we actually are working in a GP clinic within a hospital, so we do our own iron infusions managed on the ward or day procedure unit. And so this is one thing that I think we really should know, even if you're not actually giving the iron infusions, you should be able to discuss with the patient what are the risks involved. So generally, very, very safe. They happen all the time in Australia, but things can go wrong. And of course, like all medications, anaphylaxis is potential, even if they've had previous iron infusions that they've tolerated without incident. In particular, because it's an intravenous infusion, the risk for anaphylaxis is quite high if it does occur, but we still manage it just as we would any other case of anaphylaxis. The most important step, of course, is to stop the infusion. Now, the next most common things that people will actually experience and are definitely worth mentioning to patients is headache and sometimes a sense of dizziness as well that kind of tie together a bit. So I'd kind of lump those together as one single answer there. And similarly, things like abdominal pain, nausea, vomiting, constipation, or diarrhea, really it's gastrointestinal side effects. So just as people often experience these kinds of things when taking oral iron, some people still get those same effects when taking an iron infusion. So worth warning the patient about. Flushing is particularly common. In particular, a very warm, kind of unpleasant sensation of flushing, which is often alleviated just by slowing down the infusion. Tachycardia, also quite common, and hyper or hypotension. The blood pressure can go up or down, and again, slowing down the infusion tends to settle that down as well. Bronchospasm can be present as well. And the one thing that I think we are particularly good at warning people about is the risk of skin staining. So if the cannula isn't properly inserted and the iron does extravasate, leave the vein, go underneath the skin, it can actually stain the skin permanently like a tattoo, and that can last forever. You can try similar kind of laser tattoo removal techniques, but it doesn't tend to be overly effective. So always worth warning, especially when it's, say, a young female that is particularly concerned about things like that. Now, you can get muscle spasms and pain as well, which can be for quite some time after the infusion, so worth mentioning to patients. And that ties in a little bit to the next thing, which is hyperphosphatemia, which is something that probably is explained to patients. There is a fairly profound risk of hypophosphatemia that can require admission and has unfortunately led to patients becoming very sick and even a few deaths as well. So making sure that you've actually checked phosphate levels, if need be, supplement in the short term, and keep an eye on them for a little while after as well. Any symptoms, be sure to check phosphate levels and supplement accordingly. Good summary in ETG about that as well. If you want to warn them about what to look out for, it's a bit of irritability. They can have paresthesias, muscle weaknesses, all the way through to hemolytic anemia, delirium, seizures, and arrhythmia as well. So can be pretty nasty. All right. Of course, we have more questions on the way. So let's get 2 minutes back on the clock for our final question for case number 1, and your time starts now. All right, time is up, and again, just make sure you're making sure you're up to the time for the next question as well. This rash, oh boy, this is one of the few times where you may experience anal flutter. This is one of those terrifying diagnoses. This is, of course, Stevens-Johnson syndrome. So, to make sure you would actually get all 3 marks available for this question, you need to specify that you're calling 000 for an urgent ambulance transfer to the emergency department for suspected Stevens-Johnson syndrome. If you're specifying that you're calling for an emergency ambulance, that it is an urgent transfer you're requesting, and suspected Stevens-Johnson syndrome, you're going to get all those marks there. If you were to just say ambulance transfer to ED for suspected Stevens-Johnson syndrome, I think you'd be missing out on that mark. They do like you, even though it's kind of implied by the fact you're calling for an ambulance. They like you to actually specify urgent. Likewise, if you just say ambulance or transfer to the emergency department, yeah, you're going to get a mark, but you're not showing that refined consultant level knowledge that they're really trying to hunt for here. So you haven't specified urgent, you haven't specified why you're sending someone or why you're making that referral there. Now, Stevens-Johnson syndrome is absolutely terrifying. There's not a whole lot we can do other than that supportive management, keeping that patient in a very controlled environment, obviously stopping the offending medication. And this is a pretty classic situation where it's within the first 2 months of starting a medication. Can be any medication, but azathioprine is one that's known to be associated with Stevens-Johnson. And of course, trying to maintain skin integrity as best as you can.